everybody. Thank you for being here tonight. In the interest of time, we'll go ahead and get started while people continue to trickle in. By way of introduction, my name is Taylor Daniel. I am a fourth-year medical student and the RAMS board liaison to the Education Committee, along with Dr. Carly Hebard.
I'm Carly Hebard. I'm a second-year resident at Ohio State University, and I'm one of the RAMS board at large, working with Taylor.
So as you all know, we're here tonight to have a discussion on clinical teaching in the emergency department. So I think there are some unique challenges, the fast pace, the variety that you see in the emergency department, but also some unique opportunities for clinical teaching. So that's what we're going to discuss tonight. And of course, this was really geared at learning how to teach medical students. However, a lot of what we'll discuss could be applied to learners at all levels. So we're very excited to hear from our 8 fantastic panelists who have graciously agreed to give us their wisdom that they have learned in their years working as educators in the emergency department. So a little bit on the structure of the evening. First off, we're going to have all of our panelists give a brief introduction. And then the first 25 minutes or so, we have some pre-written questions that we'll be addressing to our panelists. And then we're going to open the floor for questions from the audience. So the way that we're going to ask that you guys help us with this tonight is, rather than turning on your mics, we'd really appreciate it if you would direct message Carly. And you can do that at any time. It doesn't just have to be in the second half. If you think of something 10 minutes from now, please go ahead and send that. And then we'll ask our panelists directly. All right, so with further ado, I will go ahead and have our panelists briefly introduce themselves. So to start alphabetically, let's start with Dr. Gottlieb.
Hi everyone, thanks for having me. So I'm Mike Gottlieb. I'm at Rush University Medical Center in Chicago. I'm an associate professor of EM. I run our ultrasound division, and I'm also the fellowship director for ultrasound. And I'm a core faculty and med ed nerd, basically.
Thank you very much. Now, Dr. Kim.
Hey, thank you all for being here today. I am Albert Kim. I am one of the assistant residency directors at WashU in St. Louis. I am also our education fellowship director. I initially sort of started my career in ultrasound and then sort of migrated towards education. In sort of my area of interest is bedside teaching. So I actually love this topic.
Thank you very much. Now, Dr. Lawson, please.
Hi, everyone. I'm Luanne Lawson. I am the Senior Associate Dean of Medical Education and Student Affairs at Virginia Commonwealth University. And I've run the gamut of things in the emergency department, from community practice to being a recovering clerkship director and now into a more administrative role.
Thank you very much. Next up is Dr. Nordberg.
Hello, I'm Alex Nordberg. I am the Assistant Program Director at UMass in Worcester. I also started off with an ultrasound fellowship and kind of migrated towards med ed. I found that I really loved the teaching aspect of ultrasound and kind of just migrated towards med ed in general, and then became APD over at UMass. Excited to be here and excited to hear what everyone else has to say tonight as well.
Thank you. Next up is Dr. Pedego.
Hi everyone, I'm Ryan Pettigo. I'm one of the Associate Program Directors in Emergency Medicine at Harbor UCLA Medical Center. I was a clerkship director for 5 years before transitioning into this role. Really excited to be here, and I kind of fell into a faculty position essentially after graduating residency, and ever since then I've been doing faculty development for myself, and so hopefully can share some of the tips I've learned along the way myself.
Thank you. Now, Dr. Shaver.
Hi, everyone. I'm Erika Shaver. I'm from Morgantown, West Virginia. I'm the Vice Chair of Education and Training and the Residency Program Director at West Virginia University. Quite honestly, when I came into residency, I wasn't really sure what academics and being an academician was all about. And I thought I wanted to go work in a rural emergency department back in my hometown, which is a really small town with an 8-bed emergency department. And throughout some leadership positions in residency, I realized that I was an education nerd and I liked coming to conference and I wanted to come on vacation. And so that's how I knew I was destined for some sort of medical education career. So I've been doing that for about 10 years now, working clinically, obviously, with medical students and residents and advising both, and really enjoying that. So I'm glad to be here, and thank you for having me.
Thank you very much. And now Dr. Tennill.
Hey everyone, I'm Bobby Tenola. Thanks for having me tonight. I am the clerkship director at Southern Illinois University in Springfield, Illinois. I was a community doc for my first couple of years out of residency and then switched over to academics and have been the clerkship director for the last about 3 years or so. In addition to med ed, I have a special interest in simulation as well. So thank you all for having me tonight, and excited to be here.
Thank you. All right, and last but not least, Dr. Tondt.
Hi everyone, I'm Julie Tondt, also excited to be here. I am the Medical Education Fellow at Eastern Virginia Medical School. So recent graduate. My senior year, I was in charge of the 4th year medical students. This year, I handle the 3rd year medical student rotation. I also have an interest in sim, so excited to be here.
All right, everybody, thank you so much. We won't waste any time, and I'll get to our first question, which is for Doctors Nordberg, Tennill, and Lawson. And if you would, please tell us about how you became interested in teaching and some of the challenges you think are unique to teaching while on shift.
So I can take that first, I guess. So how I first got interested in teaching, I think the way a lot of people have a first time leadership position within residency or something like that, I was chief resident at UMass, where I'm now APD. So I've kind of run that gamut of intern to APD in one institution, but I really enjoyed my chief year. Certainly there are challenges and everything like that, but I was in charge of planning conference. And so I, liked the way we did conference in certain ways, wanted to change it in other ways and things like that. So that's actually one of my ongoing projects now, is kind of revamping our curriculum. So it started back from my chief year. And then, like I said, I had done an ultrasound fellowship and, enjoyed it. I'm glad that I did it. I don't regret doing an ultrasound fellowship, but then just kind of realized that my overall interest in what sparked me to, what I wanted to do day to day was more of the education side. So I went that route. And then challenges on shift, emergency medicine, right? So you don't know what's coming in. You can't necessarily prep for like the day's lesson or something like that. You have no idea what's coming in. So you don't know if there's going to be a STEMI, a trauma, something like that. So kind of being able to be on your toes, not only clinically, but also as an educator, and being able to shift moment by moment for your learners, definitely a challenge.
I'll give my how I got my start in academics. So when I first came back from community practice, I really actually envisioned myself as being more of a resident educator. I really wanted to focus on clinical education, especially filling some of those gaps between what happens at the tertiary care academic center and what you actually deliver in a community center, and helping residents bridge that gap. I would describe my interest in education as a field promotion. So I essentially became the clerkship director when there was a sudden need, and the prior clerkship director became ill. And I think that was probably one of the most humbling of experiences of recognizing when you don't have the expertise that you need to be a great educator, and to be able to really design curriculum in a meaningful way. So I actually went back and pursued a master's of adult education to be able to develop more expertise and hopefully provide medical students with a better experience. along the way. And so I said in the very beginning of my academic career, I would never do anything administratively or research related. So somewhere I made a wrong turn, but the good news in that is there are opportunities to redefine your path as you go along. I think one of the hardest aspects of teaching in the emergency department and is really trying to engage learners regardless of their interests. So I went from being an elective clerkship director to implementing a required M4 curriculum. And so all of a sudden, people are not so interested maybe necessarily in emergency medicine, and helping them figure out how they can connect emergency medicine to what their specific interest is, I think helps bring about value as a person for them. But there's also invaluable lessons and things that we get in return in the ED when our partners can work most effectively with us. So I think that's one of the challenges, but the real opportunities for us as EM educators.
Again, I got interested in education probably as a second year or third year resident when we had specific education shifts, and we're able to kind of mentor and work with students specifically on shift with no other kind of goals of the shift other than to teach and talk about our thought processes. When I got out of residency, I thought I would probably do community practice for 5 years or so and maybe someday work my way back. It didn't take very long. It took about a year. I really enjoyed the working with the students on shift, the talking about medicine and why we do what we do and why we think the way that we think, as much as I did the practicing of it. And so it was a very easy decision to switch over and start working with the residents and students and have that opportunity on a daily basis to do those things both in the clinical setting and then outside of it as well. I think we have a unique ability as ER docs. We think about things in a, I don't want to say simple manner, but kind of a heightened importance, the key things about patients that we see and the key things that need to be done. And I think that puts us in a great position to teach the big points and the take-home message with students. I think one of the most difficult things about teaching and Luanne mentioned a great one there as well. I think in addition is the managing the balance between autonomy and the demands of the emergency department. So, it is important as an educator, especially with sub-Is, that our students feel that they have autonomy, that they have patient ownership, that they're putting in orders, writing notes, or having some sort of a say in what's happening with their patient. And it can be tough with the department and the speed of the department and you wanting to get up out of your chair and make things move and make dispositions, to take the time to listen, to give them that autonomy and to make them feel like they have true ownership of the patient. And so balancing that need for efficiency and great patient care with allowing the student to have that autonomy and learn how to be a patient manager as well, I think is a challenge and a skill set that comes with experience, and still learning every day on that, how to manage that.
Thank you all for answering that. We have a next question is for Dr. Pedego. How were you interested in teaching? And then also, have you in particular identified any specific teaching styles that you feel really connect with students going along that theme of autonomy?
Yeah, so I guess a brief thing on how I got into teaching, similar to Dr. Lawson. I kind of, I was chief resident and then I fell into a clerkship director position due to a relatively unexpected retirement of the current clerkship director. And then I realized as I started in this role, I was like, wow, I've learned a lot of emergency medicine and almost nothing about teaching. And so I ended up doing a med ed fellowship at UCLA, and then most recently just finished a master in health professions education degree, and also did a few other faculty development courses. And I would say that, one of the things that kind of Dr. Lawson also talked a little bit about is really in terms of the learning climate, like how to get a learner engaged and interested. And part of that is also seeing what the relevance is to the learner that's in front of you. And so the, MS4 who's on their sub internship in emergency medicine is doing emergency medicine is going to be really interested in probably anything that you're going to teach them on any cases, right? Because all the things by definition have pretty intense learner relevance to them. However, when you have the off-service anesthesia or family medicine or internal medicine, right, part of making things stick is not just communicating stuff in an effective manner, but communicating why it's important to that learner. So when you think of adult learners, one of my co-faculty, Diane Birnbaumer, likes to say, you can just imagine that all these adult learners have what's in it for me kind of like plastered to their forehead. And so whenever you're thinking, of an adult learner, when you think of like a third grader, right? You say memorize all 50 states, right? They'll do it. They'll 100% they'll do it, and they'll go home and they're going to memorize all 50 states, right? If you told that to a anesthesia, sub intern, right, they would be like, "What are you talking about? I'm absolutely not doing that." And so, first thinking, what's in it for this learner? Why are they here? And how can I make that teaching experience relevant to their specific interests is really the key in terms of making something stick. Because you could be the best teacher in the world, but if they don't care, if you haven't established why it's important for that learner to understand the material that's being conveyed in that setting, then even if you're really effective, they may not actually care. And then I would say in terms of the teaching styles or things that I'd recommend that really like stick, I would say if you're a junior educator, just have some sort of framework. There are many frameworks out there. I would say if you don't use any sort of framework, just try one. Like for instance, there's the 1 minute preceptor would be a very easy framework. And if you're not doing those types of things on your next shift, you'll already be a better educator. So the 1 minute preceptor is a set of 5 micro skills. And the first is getting a commitment. And so that's really important. If you're receiving a presentation, we've probably all had a presentation where you give your presentation and say, oh, okay, so you're going to get a CT scan, right? Or, oh, you're going to get CBC and LFTs or something. And then maybe your learner was, or maybe they weren't, right? And so making sure that they commit to a plan. And then the second skill is trying to understand their clinical reasoning. How did you come up with that plan? Because those two things are both important. One, is the plan correct? And two, if it is or if it isn't, how did they get there? And so trying to understand like what was turning in their head to come up with the plan that they presented to you is critically important, because you may decide, if you didn't ask, you may come to a wrong assumption onto why they came up with their plan. And so you really need to understand where the learner's coming from. And once you've done those two things, made them commit, understand why they're committing to the plan they're committing to, then it's relatively easy. You tell them what they did right, you tell them what they did wrong, and then you teach them something, right? And so if you do those types of things on most encounters, if you're not doing that already, you're already going to be probably like twice as good of an educator as you are currently if you're not using any sort of framework. And then I guess the very last thing I would say is there's really only 2 ways you can know something about a learner. You can either ask them something or watch them do something. And the latter part we do way too infrequently. And so really direct observation is such a critical and underutilized skill. You could have a sub-intern do their entire sub-internship without anyone ever watching them do anything, right? They could just go in the patient room, come back and report, go in the patient room, come back and report. And so I would just say if you're not directly observing your students, you're missing a really critical part of their evaluation.
Thank you so much for those pearls. Already just as a learner, thinking about some of the things you mentioned there at the end. I mean, I could probably count on one hand the number of times I was directly observed and learned some of the best things. So lots to think about there. Thank you. The next question is for Dr. Tondt. So in your work as a recent resident and current fellow closely supervising medical students, can you identify any particularly good teaching opportunities that you like to capitalize on during your shifts?
Yeah, I think like other people were saying, it's, always something different on your shift, and it's hard to prepare kind of what's going to come into the door. But I like bringing the medical students and having them, right up on front at the beginning of the shift. I'm like, okay, you may see me get up real quick and they may say, go to the hallway, go to this room, just, get up and follow me. And I think that that's really where you're going to learn, because I think a lot of times we as faculty or attendings may forget to say, oh, come with me to room, 2, there's a STEMI in that room. And really going into the room and saying, okay, you put your hands on the patient, you kind of take your stethoscope, listen to the heart, lungs, abdomen. I've noticed sometimes students kind of stand back from the patient and they'll stand at the door. But I really encourage students to, get right in there with me, ask the patient questions. If you think I didn't ask something, go ahead and ask. So just really making them a part of the patient encounter, and then leaving the room, discuss the patient. So, okay, let's summarize. What did we learn about that patient? What would we like to do about the patient? What is our goal? And then depending on what level, whether third year or fourth year student, kind of thinking, okay, what is our plan? What are we going to do with this patient? And I think as a recent graduate and kind of going from student, intern to kind of senior resident, now fellow, that was definitely something that I saw myself learning and others learning along the way is, okay, we maybe diagnose this patient with their sepsis, but what do they go home? Do they get admitted? Using risk stratification tools, bringing in MD Calc, doing, heart score and all that. So I think having the student involved just as much as you are, I've kind of learned has really helps with student involvement with the patient.
Thank you. Those are some great pearls. Our next question is for Dr. Gottlieb. Can you tell us a little bit more about the role of confidence in medical training and how we might incorporate this into teaching students during shift?
Yeah, absolutely. One of the things that we often focus on in medical education is we focus on this idea of competence and like how accurate are we? And the problem is that there's a whole separate area of competence which often gets lost in there. If you aren't confident in what you're doing, you aren't going to undermine yourself. You're not going to be in a state to learn. And sometimes you can, appear less knowledgeable because of the nervousness instead of actually not knowing things. And I think one of the things we should do at the start is just kind of normalize the fact that we don't know everything. We're not endless talking heads. And I think that's not just from like the expectations of the residents. And I kind of normalize that at the start of my shift saying, listen, I don't expect you to know everything because the information out there is vast and oftentimes it's random chance. If you saw necrotizing fasciitis last shift and you have a patient coming in again with necrotizing fasciitis, you're gonna be all over it. Not because you're brilliant, it's because of random chance sometimes. And if you've never seen it before, I don't expect that you would be all over it because it's a rare diagnosis. So I don't expect them to get every question right. In fact, it's okay. The idea is to learn, not to demonstrate that you necessarily know everything. And so I think, first of all, just kind of normalizing that we don't know everything makes things a little bit more, into this growth mindset, this idea that we're here to learn, not to demonstrate knowledge. And so I think that's kind of that first key. The other kind of parallel to that one is, once we don't know the answer, what do we do next? Again, I think if we imagine that, as the attendings know every answer, they just seem to always know it. Well, I think it's misrepresenting us in reality because we don't know everything. But then it just goes into the assumption that we have to memorize everything, and that's not realistic. It's also a quick way of memorizing out-of-date information. And instead normalizing that, sometimes we don't know and we look it up, so let's look it up together. And so then I actually, relish those opportunities to say, you're right, I don't know that answer either. How about we figure out how we're going to look that up? Let's figure out how we can do this on shift, because when you graduate and when you're done, whether it be a resident, whether it be a medical student, you're going to have to figure out how to look up things you don't know, especially in EM. Because our field's so vast, there will always be things we've never seen before. And if we don't learn how to look it up in that moment, well, then we're not going to be prepared to do it when we really need to.
I think that is such an important pearl, and medical students, I feel like we have this concept, just like you said, that we just have to know all the facts. One day we will have mastered them all, but that's not really teaching sustainable skills for being a clinician in an evolving medical field. So true, cannot be overstated. Our next question for Dr. Shaver is, you and your team found that getting a low third slow decreased an applicant's odds of matching into EM by 79%. So which areas, if there is a pattern that you've recognized, tend to be the areas where most improvement can be gained? And furthermore, how can educators target these areas when they identify deficits to help students early on in their sub-Is?
That's an excellent question. Thank you for bringing that up. So I think we all in emergency medicine and all fourth year medical students certainly understand the importance of the slow. And I feel like sometimes we feel like the weight of our future rides on our slow. And in former years, we used to have multiple chances at getting slows as fourth year medical students, right? We got our home slow, we got at least one away slow, we might have gotten 2 away slows, some really eager people got 3 away slows, and program directors liked it because there was lots of information that was, objective and comparable across multiple institutions, and medical students like it because they felt like they got multiple chances, right? In the era of COVID, I was just talking about this at a work meeting today, actually. In the era of COVID, I feel like the pieces of objective information that we actually have both on the program director side as well as the student side to sort of prove themselves has been decreased a lot, right? So I feel like the weight that used to be on multiple slows is now all on one slow. And so the student, rightfully so, probably goes into their EM, AI, or visiting rotation, whatever we want to call it, feeling like the weight of their next 3 or 4 years and beyond is depending upon that rotation, right? So in terms of what the lower third means, I think when you're writing the slow, I'm a big proponent of using all thirds of the slow appropriately. I think if we're going to actually divide those categories up, then we should probably use them. But I think what we found in our studies is that usually the lower third is really reserved for about 10% of all of the students that an institution might see, which obviously makes that lower third almost like a kiss of death once you put someone down in that category. I don't think that it should be that way, honestly. I think there are really solid, potentially very successful future emergency medicine residents that can be in that lower third. My personal thoughts on that is that that's what we use the commentary and the narrative section for, is to actually outline our thoughts about why the student is in the lower third, right? Nothing makes me more frustrated as a slow reader than to see someone get all upper bubbles, so bubbles going all the way down the left of the slow, and then all of a sudden they're ranked lower third, and this narrative that says how glowing they are, but yet they're in the lower third, right? Or likewise, you might have a narrative that suggests that someone is unprofessional or they're overeager, or they don't fit in with the team, but yet they got in honors and they're in, the higher bubbles as well. And so I think we have to use the thirds as they're intended to be used. And then I think we use the narrative as slow writers to sort of explain whether or not we think this person will be successful in our specialty and the objective reasons for why we put them in the lower third. Are they going to need a little extra help with their test taking and their medical knowledge? Maybe step 1 wasn't so high, maybe end of the rotation score wasn't so high. But when I read that as a program director, I'm okay with that, right? Like, I feel like I could teach a lot of people medical knowledge. I can help with test taking, remediation skills, et cetera, et cetera. If you say that they are in the lower third because you felt like they were overeager and they lacked situational awareness and they didn't fit in well with the team, or they didn't show up for multiple shifts, then those things to me are bigger red flags that would suggest that those are professionalism issues. And I would say that all of the faculty on this call would recognize that professionalism issues are probably a clerkship director or program director's worst nightmare, because often they're really unfixable, right? So I think from the program leader standpoint, I'm fine with seeing a lower third, and I definitely interview and rank people who have lower thirds if I feel like the narrative and the commentary sort of gives me the information that I need to know to help me know if I can help that student ultimately become a successful resident. On the student side of things, the slow also is confidential, right? And the student waives their right to see the slow. So I don't think that we should look at a student slow and share it back with them or send it to them via email or even tell them in an advising session exactly what it says. I do think it's our due diligence to advise students appropriately though, right? So if we see that they go on an away rotation and they have a less than stellar slow that is probably not setting them up for success in the match, I think then that's where we advise a parallel plan, and we maybe give them some feedback, again, without divulging the details of the slow, on how they could potentially perform better if they have another rotation coming up, or just, in the future in general, if they match into a residency. So our study that we did find that you still have a high chance of matching with one lower third. But I think when it all comes down to it, a good follow-up study is looking at the commentary and the narrative to differentiate the lower third folks who actually have have certain terms or hint at certain themes and that commentary that maybe would make them be successful in the future compared to people with a lower third that are not likely to be successful in the future. And my assumption is, my hypothesis is that the professionalism challenges and those sorts of things, if mentioned honestly in the narrative, would be the things that hold the student back rather than other things like test scores and medical knowledge, which I feel like we all get pretty good at helping residents with over the years. I hope that answered your question. If I missed some of it, Taylor, just let me know.
Well, no, thank you. That's, I mean, just two years out and I still feel the weight of that. And it sounds like there's good research to see if there's any patterns that you guys can look at and areas to identify that might be of help to some of those in the third that maybe deserve to not necessarily be there for those reasons. Thanks. Our next question is for Dr. Kim. We've been touching a little bit on ways that EM landscape is changing, but one of those is the increasing time constraints. So our question for you is, what do you think about the importance of teaching efficiency to medical students? You know, we think a lot about medical knowledge and things like that in general, but not always about efficiency. What are your thoughts on the importance of teaching that in the ED?
Yeah, sure, absolutely. I certainly think it is a valuable part of your education and training. I think one thing that is hard is acknowledging that when you as a resident or attending are operating through whether a med student or intern, sort of by structure, that care is going to be inefficient, right? There's going to be things that are going to happen that if you as the attending or you as the senior resident just did yourself would go much smoother. But part of education is understanding that that is part of the process. And so part of efficiency is you as the more senior person carving out time for teaching, carving out time and sort of streamlining processes so that you can let your junior learner sort of take that initiative and sort of take that responsibility and sort of absorb sort of that inefficiency in their care. The other part of that too is acknowledging that in order for a fourth-year resident, intern, a second-year resident to become a senior resident or become an attending is learning those things that are beyond just the medical side, right? And I think that's a lot of when you're an attending or senior resident, when you're trying to teach someone who's a little more advanced, where it's like, oh, I have a second-year resident or third-year resident who does know the medicine and does know most of the processes. What are the things that I can teach them? And a lot of times it is going to be those efficiency gains. And especially for people who are going to be educators, understanding that those efficiency gains really help you become a better educator, right? Like a lot of what we do is becoming more efficient in our patient care. So then we can carve out that 2 or 3 minutes to then talk to our senior resident and have that teaching moment. Sort of coming at it from that perspective is that, you know, understanding that as you become more efficient, that is actually how you become a better teacher, because again, you're able to find those more moments more frequently.
Thank you so much for that. I think it's such an interesting thing. Again, from the perspective of a student, you don't always think about how, you know, sometimes we're painfully aware of the fact that it's much less efficient when we're thrown into the mix, but just recognizing on the back end, the residents around us, the attendings around us are streamlining other processes to allow us that space. It is so appreciated when we get it. And I think it's easy not to recognize how much work goes into that when you're so hyper-focused on your own learning. So excellent, excellent tips. So our next question is for Dr. Gottlieb again. So you and some of the colleagues here today have studied extensively different teaching strategies, some of which were mentioned a little bit earlier, for working with learners under increasingly time-constrained conditions. What do you think are the highest yield methods?
So I'll start by echoing a little bit of what Dr. Pedego mentioned earlier, the idea of you have some structure, especially early on, just have some format that works with you. I want to talk maybe a bit more into a few learning theories that you can apply to some of your practice. First one is cognitive load theory. So it's the idea that in essence, there's a lot of information out there. If you overload people with too much, it makes it either too much information, too complex information, too much new information, or you don't retain anything. I know that personally, one of my lessons learned was I remember one of my first teaching endeavors as a first-year resident. We had a patient with heart failure, and I went on about a 20-minute talk about all components of heart failure to the point where I felt like I was boring myself to tears. And I covered everything I knew, all the data. And then we saw another heart failure patient, and I asked, okay, so what's the first medication we can give? And I got a blank stare, and I was thinking to myself, I was like, well, I just taught you all this stuff about heart failure, and it caused me to self-reflect and realize that I taught all this stuff. They didn't actually learn anything. And that's the end goal, right? It's not about us teaching, it's about them learning. So rather than trying to teach everything, pick a bite-sized pearl. I try to when I'm teaching, both when I'm doing and when I'm teaching our residents how to teach, I say it should be able to be summarized in 1 to 2 sentences what you taught them. You can spend 30 seconds to a minute on it, but it needs to be summarized in 1 to 2 sentences in a tangible format. So I think the first thing is teach something that is easily retainable. If it's too much, spread it over time. The second one is we learn better when we scaffold, when we build on things we already know. It could be on existing knowledge. It could be on existing things we don't know, like comparisons. For example, if I'm teaching blood clots, I'll link the likelihood of having a DVT to lanes merging on a highway. That's a concept we understand. Link it to things you already know, it retains easier. So take concepts, link them to things you already know. The third concept is spaced repetition. If you're going to teach something one-off, you got to come back to it again. It's going to strengthen their connections. It's going to make it more likely they'll actually retain it. And I'll often try to combine that with some form of safe questioning. The idea being that you ask them a question in a safe learning environment, you cause them to actually get a little cognitive strain to think it through. With the intention of that doesn't matter if they get it right or wrong. It's the thinking processes to trying to reconnect those dots that build long-term memories. And so kind of calling that back there, simple learning pearls, bite-sized pieces. Try to tie to things they already know, space it over time, and then use recall to make sure it sticks.
Thank you for those. Those are great kind of concrete things that we can think about and use. We'd also like to ask, we also spoke a little bit about the way things have changed this year with COVID-19. Dr. Tennill, we were wondering about some unique challenges and how you've gotten around some of those, in particular, like adapted teaching for procedures and things like that when we can't always be on shift.
Yeah, COVID's been, of course, very interesting, and it was pretty rough for the first few months from a teaching standpoint. Our volumes were extremely down, as they were lots of places. Our learners had very few patients to see, and at our institution, they were restricted from seeing COVID symptom or patients under investigation. Patients for a long time, so the volume decreased significantly, and of course the procedures as well with it. And so initially, our response to that was to look for other opportunities to give them exposure to high yield patients and to procedures. We attempted to do things like virtual simulation sessions to talk about differential and management for higher yield patients, and especially respiratory and COVID related symptoms. We even created a virtual procedure curriculum for our sub-I students or our resident readiness students that were going on into a curriculum or going on to an EM residency to try to give them some exposure to some high yield procedures like central lines or chest tubes or even just high important procedures, pericardiocentesis, you name it, that they were not only not seeing in the department, but not seeing in a procedure lab, as we didn't have access to that as well during COVID. And so that was tricky, and that's obviously universally across all of us, I'm sure, had many of those same difficulties. So, I think that we've been very fortunate to get back in the procedure lab, back in the sim lab, back with higher patient volumes, and the residents that we've seen and the students have really adapted nicely to it. But I think that when given a situation like this, there's still a lot of opportunities to learn and to talk about these things. And so, we really had extra time to go through the different, the indications, the contraindications, the steps of a procedure that maybe you wouldn't have necessarily on shift. And to really go into detail on that and talk about those things that maybe we wouldn't have had as much time in a busy ER shift. So not ideal. I'd much rather be putting in a chest tube with a medical student and showing them on shift. But having the time to talk about why we're doing it and what the steps are, I think is also beneficial. And I think that we've seen that the students and our residents have really hit the ground running and made the most of a tough situation.
Thank you very much for that. So at this point in the talk, we're going to go ahead and transition to audience questions. So please do continue sending those to Carly via direct message. We do have one ready to go right now, and this will be directed to Dr. Nordberg. So as a new faculty member, I struggle with giving difficult or constructive feedback. Do the panelists have any advice for giving difficult feedback or correcting errors? So as I said, we'll start with Dr. Nordberg, but if anyone else wants to chime in, please feel free.
Yeah, so this is tricky. It can be difficult feedback for different reasons. So is it difficult feedback because the learner has received this feedback before and didn't respond to it? Is it difficult feedback because it's just kind of awkward to bring up for both you, the person giving the feedback, as well as the person who's receiving it? That figuring out why you feel like it's labeled difficult feedback. So if it's the first one where the person or the learner had received this feedback before and is, for whatever reason, it didn't stick or, they didn't learn from it, I think starting the feedback with more open-ended questions, like, we all started off like, how do you think that went, that shift, that procedure, whatever. And trying to see where they're coming from, like we all learn about when we have difficult conversations with patient family members and you're breaking bad news, you always want to find out where they're starting from, where their knowledge is in the process. So you can do the same thing, giving difficult feedback. And again, I do think the importance of that is, what we had talked about before, normalizing that it's okay. And you're not going to, just because someone told you something or gave you feedback once before, doesn't mean that you A, understood it, or B, know how to directly implement it. So trying to figure out, does this remind you of something else before? Do you feel like you got this feedback before? And helping them to make that connection to be able to use the feedback better, or so that you can help yourself give them the feedback in a way that will be useful for them. The other situation where it's feedback that maybe more feels awkward, the professionalism feedback, things like that. That I definitely think needs to be, I think you need to be a little bit more aware of your surroundings and when you are saying this, in addition to how you are saying this. So, you don't want to make a big deal about pulling this person aside and, that sort of thing. You don't want to make it necessary. You don't want to make them feel singled out and awkward about it more than they already do. But obviously something needs to be said, right, in these situations. And I think just calling for something like that, calling direct attention to it. So, hey, you showed up late today. Hey, you have been showing up late for a couple shifts in a row. Like, what's going on? Are you okay? When it's things like that, when it's more like personal professionalism issues, I think the first thing is to make sure that the learner is okay, mentally, physically. A lot of times it's something going on at home or something like that. And then if it truly becomes a pattern, you got to call attention to it. The sooner that people can learn from it, the better, and to figure out why it's happening and how can I help you prevent this from happening in the future. And helping them to see why people see their behavior or their thought processes or their language as a problem, and making sure that they know that you're not trying to just, be hard on them, but you're helping them to become a better person, a better physician, so that they can go on to have long, prosperous careers, and taking care of patients, as well as having good relationships with their colleagues.
Thank you. Thank you for that explanation, and thank you guys for the audience question. Dr. Kim, same question.
Yeah, sure thing. I'm actually going to reiterate what Dr. Nordberg said about really taking your learner sort of into a private space. And I think I would say I would just normalize that for all feedback, both good or bad. So it's standardized across. So knowing that that's your process, that they're not going into that knowing like, oh, this is how I get bad feedback. This is just how I get feedback. I think getting the learner's perspective, how do you think X went? How do you think Y went? But most of all, coming from it from one, we're all learners. We all have things to improve on that no one's going to be perfect. So whether that's just, hey, we need to talk about this procedure where I think you can improve, or if it's a patient interaction that can be improved, acknowledging that we all have to learn this information at some time. And, there are certain things that, yes, may come naturally to some and not to others. But again, everyone has something that they're going to struggle with throughout their career. So I think acknowledging that, and acknowledging that you as the person giving feedback really is coming from it from a perspective of, I want you to get better, right? Like, I think once you sort of establish sort of that perspective, yes, some of those conversations are going to be awkward, but I think it does smooth things over as long as your learner understands that you really are coming from it from a perspective of, this is how I want you to get better so that you can be successful in your career and you can be successful within EM. Now there are like various different techniques of like how to give feedback for professionalism or how to give feedback for procedure or medical knowledge. But again, I think acknowledging that, kind of normalizing that, one, the way you give feedback is sort of standardized across both good or bad, and then sort of establishing that your motivation of giving feedback is really to make them better. Now, if there are things where it does turn into a professionalism, or it does seem like that learner is not accepting that, then fine. There may be times where you have to escalate that, whether that's to the clerkship director or to their program director if it's a service resident, or the dean. But again, a lot of those things really can be managed sort of in the moment.
Thank you very much, both of you, for your thoughtful answers. Our next question is for Dr. Lawson. And it is, how would you say your teaching style has evolved over the years during your establishment of the 4th year EM clerkship, development of the NCAT, and involvement with CDEM, pardon me. What major pearls would you give to new educators that have become priorities to you while supervising medical students in your clinical practice?
Great questions, and a lot of them all packed in there. So I think as things have unfolded in my career, I think I shared some of the same struggles that you all mentioned about giving feedback. I think part of this is actually thinking about really feedback being a gift. That's a gift that we deserve ourselves and that we should be able to give our learners. And so thinking about how to build some of those pieces into the structure of what we do and to standardized processes. So we have a tendency otherwise to really only think about things like feedback in a negative way. Oh, I've got to get this bad feedback. So as a clerkship director, very early on, that was a huge struggle, especially as a transition from elective where everybody was super engaged to going to a required clerkship where there was a pretty significant variability in those things. And so instead of trying to focus on that, we try to put processes into place so that everybody at the end, within 1 hour of your shift. Like, this has to be a shared responsibility between students and faculty. And I think that's really important as adult learners, that we all own a piece of this and piece in that success. And so I would ask that all learners would approach faculty within an hour and say, hey, give me your feedback, and to be able to incorporate some of those, to be able, so that everyone was ensured some type of feedback, both positive and negative. I think we really need to think about, how do we change the culture in which students, in which our learners see feedback? Because right now, I think the culture is that this is a punitive, like, if you need to get better, we're telling you this because you're deficient in some way. And so really embracing that learner mindset and the growth mindset of, this is something that's going to be expected throughout your career. How do you become a master adaptive learner? A lot of our learners actually already inherently know these things. And so the things as when you're the educator, whether you're the educator as a resident or whether it's as faculty member, the learners actually inherently in tune to this. And so I think some of the things that are hangups for us as the educator, we probably need to let go of a little bit and just embrace our own insecurities with that, and ask the learner, what is it that you think, how do you think you did? What do you want to learn? How do you want to grow? And that really, by forming more of a partnership in this, that we're able to make a lot more impact than when in that more traditional setting where we're being seen as, this is only about a grade, or this is a punitive, or this is I know more than you do because you're the more junior person. And so thinking about, how do we build partnerships, and that with our learners, regardless of the level, to be able to increase the impact of what we do. And I feel like I missed part of the end of that. But.
No, that certainly was a lot to think about. Great answers. I feel like that is such a mind shift, at least in the learner role, to think of it not as, oh, you're telling me I did something wrong, I'm bad, I'm getting a low score, and more so, no, this is how I'm getting to be the clinician that I want to be. And I think it's such an important one. Our next audience question is for Dr. Pedego, and that is, how do you build in giving consistent feedback to multiple learners during a busy shift?
Yeah, so that's always such a challenge. And, as far as feedback, really, I would say, if you are really conscientious about how you're giving feedback and how to give it effectively, it becomes much easier and more efficient to do so. And so when I'm thinking about feedback, I'm thinking about feedback is really, really supported by both the learning climate that you've generated during your shift and also the evaluation. So the basis under which you have to give feedback to that learner. And so when I'm trying to kind of manage that, I'm really, really, really taking stock into those things and making sure that the learning climate that I'm generating for that session is really positive. So that's like really simple things, but like, making sure you're giving people your full attention, using learners' names, being respectful, things like Dr. Gottlieb said about admitting your own limitations is so nice because it's disarming. It makes people feel less defensive. You're like, if you're saying like, yeah, I don't know that either, right? That kind of makes a learner now kind of feel like, okay, like I can let my guard down. I don't have to know everything. It's not like this huge power separation. And so the learning climate that you're generating is really, really important, because that same feedback, if that learner knows that you like deeply care about their success and you're really invested in them, even if you say the exact same words, how that learner will receive it versus if they think that you're like not looking out for their best interest, right, is going to hit totally different. And so, residency and all these education things, it's kind of like a coaching dynamic, right? If you hired a coach and they never gave you any corrective feedback, you would fire that person because they're not very helpful for you, right? And the other part is the evaluation part that really supports your feedback, that you have a valid basis. You directly observed a behavior or directly observed some sort of situation where you actually have a valid basis. So early on in clerkship director, people would be like, hey, can you give feedback to this medical student? They did this and this. And I'm like, no, I can't, because I didn't see it. Like I wasn't there. And I'm not actually able to come to a shared mental model of what actually happened and how I can actually intervene on something. And then in terms of the feedback itself, again, there's many different frameworks for feedback, but I will say if you could take one thing in terms of like giving feedback, once you've built up that learning climate and once you have a valid observation to base that feedback on, I would say the biggest thing is make it as low inference as possible. And what I mean by that is you're saying a very specific action or behavior, and you come to a shared model of what that means and how that behavior might be either done more if it was a positive or reinforcing feedback, or how a different behavior might be more effective if it's corrective or quote unquote negative feedback. So, if you said something high inference, like, wow, you really annoyed that consultant, right? One, not very helpful, right? But two, what you want them to do differently and what that learner believes they should do differently, there actually may not be any alignment whatsoever with that statement, right? But if you're approaching that same thing as, hey, I noticed you interrupted the consultant 4 times as they were talking to you and that seemed to really annoy them, right? Then all of a sudden, now you're kind of on the same level where you're like, there's a specific behavior that I witnessed and it seemed to have this effect, and that's kind of a launching pad for that discussion. And so for me, in terms of giving effective feedback and giving it efficiently, it's really setting up all those things that happen even before the feedback session to make the actual session itself much more productive.
Wonderful. Thank you so much. So we only have about 5 minutes left, and the way that we'd really love to close this is if every one of our panelists could give us one pearl. And I apologize, this is the rapid fire round. But I think that'd be an excellent way to close the evening. And thank you all once again for being here. It's been such a wonderful discussion.
Let's do alphabetical again, shall we? All right, let's start off with Dr. Gottlieb.
All right, so I'll lead off that. Remember, it's about the learner. It's not about us. Everything that we're thinking through, whether it be delivery of information, whether it be how we're assessing them, not making assumptions, actually trying to understand their lens and how they're viewing things, to even what Dr. Pedego was mentioning at the end, which is developing this educational alliance, developing a shared understanding of what you want to achieve out of the feedback. Remember, it's about them, not about us, and we should be adapting for that.
Excellent. Dr. Kim.
I'm going to say normalizing that we don't know everything, and then it's okay to be wrong, because I think that's what a lot of our med students and junior residents are terrified of, and acknowledging that, one, they're in a position where it is okay to not know things, and it's okay to be wrong, because that's why they're in training. That's why they're learning those skills now. And I think the next level is us as the educator acknowledging when we don't know things. And one of the skills that we do teach them is when you don't know something on shift, understanding where to go for that information, and then teaching your learners how to gather that information themselves.
Thank you. Dr. Lawson.
Practice being quiet so your learner can be heard. I think as a new attending, being able to sit back and keep my mouth shut was probably the hardest part of sort of transitioning, and so being quiet so they can be heard.
That was quick, but also very powerful. Thank you. Dr. Nordberg.
I think I'm going to kind of echo that a little bit. I think it is very hard to do nothing while you're trying to teach, learn to that, especially with ultrasound. It's so easy to be like, well, let me just take the probe and let me just show you. But like that, you're not teaching them anything. They're watching you do the scan, right? I think so. Similarly, really making sure you're understanding their thought process, whether they're, doing something, I don't want to say correct or incorrect, but whether what they're doing makes sense clinically. You want to make sure that their thought process is correct. So you need to make sure that you are letting them not only give you the answer to the question that you're asking or fill in the blank for the correct, plan or dispo that you want, but really making sure that they understand why that is the best option for that patient.
Thank you for that perspective. That makes a lot of sense. Dr. Pedigo.
I would say for me, it would be to be intentional about your teaching. We're really good at deconstructing how a central line went, or how an intubation went, or how a resuscitation went. And we talk about the behaviors that made that successful, the steps that made that successful. And if you want to be a better educator, you know, we would never just wing it for central lines, right? And so you really need to be intentional about your teaching, reflect on how feedback sessions might have gone, like reflect on how a learning climate, how the learning climate you're generating is, and really just being intentional about how those sessions went and reflecting upon them to get better, just like you would anything else. Otherwise, you're just going to coast through it, and you know, maybe you'll marginally improve over time, but being intentional will make you much more effective.
Thank you. Dr. Shaver.
I would say think about the educator or the clinician that inspired you the most when you were going through this process, and what qualities they had that were most positively received by you, whether that's the fact that they were approachable, or that they were engaged in teaching, that they paid attention to you on shift, that they came into shift and started every shift out, regardless of the situation, by saying like, hey, looks a little crazy here, but we're going to have a great day today. Nothing is going to stop us. And I always thought that people like that inspired me the most. And so a lot of times it's just being a nice, normal person and being open and approachable and engaging yourself with your student that I think can start that relationship. And then from that relationship comes the ability to teach them and the ability to give them feedback that's actually meaningful to them and that they can actually trust. So think of someone that you admired as a student and try to embody some of those qualities as well.
Well, that's a good point. Thank you. Dr. Tennill.
Hey, thank you. I think my last name's hurting me on this one, but no, I just wanted to say, I would say, you know, look to teach one big thing, one big pearl per patient. I think Dr. Gottlieb explained this well. You know, we get going, we want to teach all these facts. We might talk for 10 minutes in great depth on a topic, and we haven't reached our goal at all. You know, the student hasn't left with anything from that talk that we had. And I think one of our biggest errors is trying to teach too much in too little of time. And so if we can pick one big thing, one big picture item, one pearl about a patient case to teach and pass on to the student, they're much more likely to remember that and take that home and apply it to future cases. So try to focus in our thinking on one big thing per patient.
Excellent, thank you. Dr. Tondt.
Yes, also a victim of the last name, but I agree. So I was going to say the same thing as Dr. Shaver. Really be the teacher and mentor that I guess you looked up, or maybe you wish you had while you were a student or a resident, because they're really the people that, you know, we all have those people that we even today kind of try to be like or remember, and that's really how you, in my opinion, learn on shift. So just kind of be the teacher that you always kind of wish you had.
Thank you. That's meaningful.
All right, everyone, and I think that concludes our evening. Thank you all again for a fantastic discussion. I certainly will have a lot to think about going forward, and I'm sure all of our audience members will too.
Thank you all.